be by Dr. Love. He will be speaking on management of pediatric subluxation. After that, there is one more.
Thank you, sir. And I think we'll go straight to the subject. And when we are dealing with pediatric lens subluxation, what we are dealing with is a non-traumatic, and generally it is a progressive lens subluxation, and which leads to high myopia and high astigmatism. Visual acuity drops as the lens margin approaches the visual axis or the pupillary area. So we have to decide whether when to operate and whether to operate or not. And that decision, I think, will be based on the age of the child and the visual acuity. So the surgical options that are available in these cases, and we will go through the merits of all these surgical options later on, but these are some of the options. One is preservation of the capsular bag, and in which either a Ahmed segment or Sioni ring can be used, or a scleral fixated IOL with sutures or a glued IOL. And most important is that most of these are older children, and they will be more than 8 years at least. And when we present the first case, and what you see here, that capsulorhexis is probably one of the most difficult steps in pediatric subluxations. And we have to, with a mobile lens and the elastic posterior anterior capsule, we have to put traction on the capsular bag so that we are able to complete the anterior capsulorhexis. And once it is done, then we see the cortical aspiration is done after implantation of the CTR, and the lens is placed in the bag. And single piece or 3-piece lens, it's the choice of the surgeon, and if some of the cases you will see a single piece, and some it will be the 3-piece lens in these demonstrations. And if the capsulorhexis is decentered, we can put a relaxing cut, and then the Ahmed segment is used to fixate the bag. In this, you can see it is Ahmed segment is slightly more bulky when compared to the Sioni ring, but the advantage is that manipulation inside the bag is much less, and a 9-O-proline or Gore-Tex suture should be used, but not 10-O-proline, because over a period of time it may cut through the tissue and the lens may subluxate again. So we'll go to the next option, which is the Sioni ring. And in this case, you can see this is almost more than 180-degree subluxation, in which again the capsular hooks are used to complete the capsulorhexis. And then once it is done, towards the subluxated side of the lens, we make a scleral pocket and scleral flap. And in this, you can see the Sioni ring is sutured, and the problem is rotating in the bag. So here you manipulate the bag more when you are putting in the Sioni ring, and if you can do it comfortably, sometimes it becomes very difficult. In one of my cases, due to the small size of the bag, the ring came out in the sulcus again, and then once it is in the anterior chamber, it becomes very difficult to reinsert again. And as we did in the previous case, it is sutured to the sclera, and the lens is well centered. And most of these cases are older children, so we try to avoid a posterior capsulorhexis, and if needed, early YAG in post-operative period as soon as you see indications of posterior capsular opacity. So next, I will go to a third option in similar case. In this, what had happened, the other eye we had used only CTR, and the lens had got well centered. So I was not prepared with a Ahmed segment on or a Sioni ring in the other eye, and to my surprise, after the lens was implanted, the CTR was implanted first and then the lens. So what you can see here in this, a 3-piece lens has been implanted in the bag. Posterior capsular axis is done, and after that we notice that still the lens is grossly decentered. So what one innovation I did in this case was just use a 9O proline, and that pierced the capsular bag with using the CTR as the anchor, and we sutured the CTR to the sclera, and after that the lens got quite well centered. This is one option, but has the risk that slightly more manipulation can tear up the bag totally, and the whole thing will become unstable. So now this is what I have been leaning towards lately, because all these capsular fixation bag over the long period of time, the lens starts giving way from the other side also. There is a lot of fibrosis, though almost all of them have been maintaining 6/9, 6/12 vision, but when you see it through the slit lamp, you always fear that what would happen to this bag over a few years down the line. So a safer method can be leaving the eye, doing a lensectomy and leaving the eye aphakic for a future scleral fixated IOL at an older age. And a neatly done lensectomy may, and a good compliance with spectacles after that may give a equally good result. So this is one of the surgical options we have in subluxated lens. Next is, what if the bag subluxates? As I had told earlier, that it is a progressive disease, so over a period of time, the bag may give way from the other side and the lens may again decentered. But since the capsule is already fibrosed, a very simple method can be used for fixation of the bag, in which the haptic within the bag can be used as an anchor for suturing. And as you can see, we pierce the bag at the haptic optic junction, and from there it is brought outside and sutured to the sclera. So this is another option. With paucity of time, I think I will skip this beyond this. And final option, what we have is a scleral fixated lens. Again, preserve it for older children, maybe around 12 years, 15 years. If you are operating, you can do a scleral fixated lens as a primary option, in which a lensectomy is done. And as you can see, this is almost 270-degree or more subluxation. So we did a lensectomy, and care has to be taken that cortical fibers don't fall in the vitreous cavity. So first make a opening on the anterior capsule and anterior side of the lens, and then probably from the equator side, we start removing the lens, and the attached portion of the lens is taken off last. So in this case, as you can see, unfortunately, I'm not able to see the time bar, and I'm not able to fast forward it. So after you can just indent the sclera a little bit to see that the attached portion, whole of the bag is removed, and then after that, using a 9O proline, scleral fixated lens can be implanted. And these children also, if you do in a neatly done surgery, they do quite well. And that's all from my side. Thank you so much.
Thank you so much, Dr. Love, for your excellent presentation. And I think you have shown absolutely stunning type of some of the subluxated cataract.
Thank you, sir.
So this